Hi all, welcome to the second web series that Dermapen India is doing. It's great to have you all on board. Today our topic is indications for microneedling and versatility of Dermapen 4. Please feel free to ask for questions alongside the ongoing webinar to make it more interactive, and we will try to accommodate most questions to today's topic and discuss. Here I would like to invite Dr. Andrew now to share his contagious excitement with us and take us through today's topic. Welcome, Andrew.
Thank you kindly.
Over to you, Andrew. You can take it on from there.
It is my absolute pleasure to be back for session number 2 with India, live from my lounge here in Paris. Welcome to those of you who were unable to make last session. Today, we're going to be covering indications with microneedling, but the versatility we can achieve with Dermapen 4. Just to explain the format again, these sessions are mini webinars really to explore innovations, tips and tricks, protocols, indications, and combination therapies for working with your Dermapen 4 and DP dermaceuticals. So we have a condensed, informal way to present the information. There's no slides, there's no PowerPoints, there's nothing written down, but I'm going to endeavor to keep these sessions as exciting and as inspiring as possible, whilst sharing everything I possibly can for today, but also over the next couple of weeks as well. For interaction, because we have an unprecedented number of attendees for today's session, if you simply refer your questions to the question and answer section on the middle of your page, then that will go to our team of moderators, and then they will send those questions over to my computer screen. So we're looking for questions which will relate into today's topic, and these will be the ones which I can answer live. For any questions which don't relate into today's topic, either these will be referred to from Dermapen World India, or I will be in contact with you outside of today's forum, just so that we keep on time as well. Please, we would love to hear your experience via social media, but also share your learning. And for Dermapen World, you can easily find this on Instagram and Facebook, but also add Dermapen World India for Instagram. And for Instagram, sorry, that's a Dermapen_India. And then for Facebook, we have Dermapen World India and Dermapen World. You are also more than welcome to add me onto Instagram. My Facebook is now currently full, but my Instagram is Dr. Andrew R. Christie, all in one word. And this way we can keep the information, the interaction continuing on. So, when I look at the microneedling story, since its establishment in the early 1990s, we've always referred to this treatment as being CIT, which stands for collagen induction therapy. However, I have some personal challenges and limitations with that terminology, because this would imply that your Dermapen and microneedling procedures would only be beneficial for patients experiencing anti-aging, so deep and superficial rhytids, for treatment of scar tissue, especially post-acne scars, but also for treatment of striae or for stretch marks. That's 3 things. Let's consider, though, that the number 1 reason why patients are seeking aesthetic intervention in the Indian market is for dyschromia, so hyperpigmentation. We also understand for the local demographic in India that patients are also looking for aesthetic solutions, particularly when it comes to acne management, and then following acne, reduction and revision of post-acne scar tissue. So it's now about updating our technology and techniques above and beyond the traditional collagen induction therapy story, so that we see more value with our Dermapen device to take us above and beyond the 1990s collagen induction therapy. But we are now using this device for more than just anti-aging, for more than just post-acne scar tissue, but also for more than just treatment of stretch marks. Now, when I add up in my mind the number of indications that can be treated with Dermapen, for the aesthetic market, I've come up with a figure in the past of some 78 indications. But when I also have a look around the world and see other elements, including the gynecological market, the urological market, the trichology market for hair loss, traditional dermatology, the surgical market, moving into podiatry and even the veterinary market, I see above and beyond over 120 indications for the Dermapen 4 device. As a heads up, I'm going to share some of the strangest indications with you at the conclusion of today's session. So you're probably thinking, how do I come to such a large figure? How did I get to so many indications? Was there some major clinical that I read? Was there some major clinical undertaken with thousands and thousands of patients? Was there some library of books that I've gone through in order to get these figures? I'm going to make this a lot simple. It's getting back to skin 101 and understanding where the major cells are, where they're sitting within the skin, what their role is to maintain balance, integrity, and function of the skin, and how the intervention of regulatory growth factors can positively influence those cells to create balance. So with this process, I really want to get right back to basics of understanding key layers, sublayers, key cells, location of these cells, but how these interact with the controlled wound healing response initiated by a Dermapen 4 procedure. So, beginning at the hypodermis or the subcutaneous layer. When we look at composition of cells, we're looking at around about an 87% composition of around about adipocytes or fat cells. For the aesthetic perspective, these fat cells from a microneedling perspective are not going to be much use to us. We do understand though that for true collagen induction therapy, the cell which produces collagen, but likewise also produces elastin, glycosaminoglycan or chains of polymucosaccharides, hyaluronic acid, but also glycoproteins, is a fibroblast. So automatically we understand that if you want collagen induction therapy, then you need to be activating a fibroblast. The fibroblast does reside in the hypodermis, but it's at a very small concentration, arguably only about 5 to 7% composition. So we see that there is value with the hypodermis, but as we explore now to the dermis itself, we're going to see that there is further value, particularly for collagen induction therapy. Composition-wise for key cells within the dermis. Our sublayers, papillary up the top, reticular down below. The primary cell found is a fibroblast. Now, in this case, by comparison to the very small, just 5 to 7% composition found in subcutaneous layer, we find it at a very abundant, almost 85% composition within the dermis as part of the extracellular matrix. So immediately, as a microneedling expert, I know that if I want true collagen induction therapy, if I'm going to treat wrinkles, if I'm going to revise scars, if I'm going to treat striae, there's no benefit treating more superficially in the epidermis where there's no fibroblasts, but also by comparison to the very small amount of fibroblasts found within the hypodermis, with an 85% concentration in the dermis, this is the area that you ideally want to be directly treating and targeting. What we also find in the dermis is 10% composition of macrophages. This is important because the macrophage and also health of the patient will be instrumental for your autologous healing and regenerative process and enabling faster repair, faster healing, less downtime, and a more dramatic response as part of regenerative medicine. Bear in mind, though, we also need to concentrate that particularly abundant around papillary dermis, we have our capillary content. We have our vascular activity. And so we also understand that not only is the dermis going to be important for collagen induction therapy related indications, but because of the relationship between the extracellular matrix and this vascular activity, we're going to understand that the dermis is also going to be valuable for vascular related indications. This is going to include things such as rosacea. This will also include telangiectasia, but this can also relate in your treatments for alopecia. Now moving on up to the epidermis. So the epidermis, we've got some challenges socially and culturally, particularly in medical aesthetics. The general consensus is why would I want to treat into the epidermis? I don't see enough blood. Why would I want to treat into the epidermis? It's so superficial. Isn't this an area that I should just hand over to my nurses? Isn't this an area that just needs to be handled by the beauty market? Is there value to treat within the epidermis? Am I going to be able to see any success for treatment indications? And can I deliver dramatic skin correction even if I'm not drawing blood with my Dermapen 4? Let's assess. So the epidermis is broken down into 5 sublayers from bottom up: basal, spinosum, granulosum, lucidum, corneum. With this, I want to highlight that the most dominant cell found within the epidermis is a keratinocyte. It accounts for 90 to 95% of cell composition. This is highly abundant. The keratinocyte is found in basal epidermis and then undergoes the process of keratinization until eventually a fully keratinized keratinocyte then becomes sloughed off as a corneocyte in stratum corneum. So already we're starting to see that the role of the keratinocyte and the role of keratinization are going to be very important, particularly for conditions where this slows down. Think milia, think keratosis pilaris, but even think acne. Now, the second most dominant cell, we move from the keratinocyte to the corneocyte. The third most dominant cell, only accounting for around about 3% of cell composition in the epidermis, is the melanocyte. And why this is surprising is because for such a small composition, gosh, it has such a massive impact and power for dyschromia. So uneven skin tone and color, whether that is hyperpigmentation or whether that is hypopigmentation. What we also see within the epidermis is going to be Langerhans cells, continuing on the work of macrophage, but also Merkel cells registering sensation and also registering experience. So I want to show here in just a very, very simplistic way that 3 layers of skin from bottom up: hypodermis, dermis, epidermis, no sublayers in the hypodermis, 2 sublayers in the dermis, papillary up the top, reticular at the bottom, 5 sublayers in the epidermis, and from base upwards, basal, spinosum, granulosum, lucidum, corneum, with the lucidum being concentrated particularly around palms and soles of the body. What I also want to add at this point is that for collagen induction therapy procedures, the key cell you need to be targeting is a fibroblast. It is most abundant in the dermis at an 85% concentration by comparison to just the 5 to 7% concentration that is found in the hypodermis. What I also want to show with this is particularly the value of the epidermis. The keratinocyte, as the most dominant cell, is responsible for renewal and refreshment. The keratinocyte also has a relationship with the melanocyte for the melanogenesis process. So the epidermis is important. Although there are no blood vessels, there's no vascular activity within the epidermis, which means no blood is going to be drawn, the epidermis is a successful, valuable area depending on the indication that you're going to treat. How does this now link into indications that I can successfully treat with my Dermapen 4 device. The origins, the philosophy of this device and of automated microneedling is to use the small microchannels to instigate a controlled microtrauma. In the case of Dermapen 4, at full speed, this is now delivering an unprecedented 120 revolutions per second, and with 16 33 gauge needles in the cartridge, this is now going to deliver an unparalleled 1,920 puncture channels per second into the skin. So as a modality completely by itself, no combination therapies, what your Dermapen device is now instigating is a controlled and a resolved wound healing response. The skin's wound healing response is broken down into 3 subcategories. So initially we undergo hemorrhage, hemostasis, and then our 3 traditional phases are inflammation, followed by proliferation, followed by maturation. And it's our influence, our manipulation, control of the wound healing response via the microneedles delivered and administered by Dermapen 4, which now creates the answers and our solution for the indications that we can safely treat. The aim of the inflammatory response is to release regulatory growth factors. In regards to these regulatory growth factors, these are able to manage, balance, direct, guide any chemical message or signal as part of the general functioning of each layer and sublayer of the skin. As such, whilst we could discuss thousands upon thousands of growth factors, I really want to explore some key growth factors, but connect them back in with a key cell. The growth factor which manages the process of keratinization, but the growth factor which manages and balances the keratinocyte itself, no surprise, is called keratinocyte growth factor. The growth factor which determines what is too much pigment by comparison to what's not enough, produced by the melanocyte, is called melanocyte growth factor. The growth factor which directs, guides, and determines the difference between scar collagen by comparison to scarless collagen is called fibroblast growth factor. And 2 growth factors which manage angiogenesis, the growth and development of capillary network, the durability of this capillary network in papillary dermis and also in hypodermis, are called vascular endothelial growth factor, but also platelet-derived growth factor. So what I now want to do is link these growth factors into the histology or the physical cells that we've discussed to now open up the opportunity for the indications that we can treat. It's the release of these growth factors which now promotes balance, which now promotes regulation, which now promotes management, but now promotes influence of the cells itself, but the biological processes that these cells undergo. Following the inflammatory response, the proliferative wound healing response now is managing collagen deposition. It's the growth factors which determines the type of collagen, whether that's scar or scarless, the placement of that collagen and the development. But we also understand that the proliferative wound healing response manages angiogenesis, the growth and development of new capillary networks. So let's establish, working from the top of the skin in the epidermis, what are you going to see if a keratinocyte, whose purpose is to undergo the process of keratinization, is not functioning the way that it should? Challenges and problems with keratinization and the keratinocyte are going to include milia around the under eyes. What we're also going to see is keratosis pilaris, particularly at the back of the arms, where keratinization is unable to effectively desquamate But what we can also see, particularly in male patients, in extremities or acral areas, is known as stuccokeratosis. So we understand that if there is an imbalance with the keratinocyte, the most common cell found within the epidermis, 90 to 95%, what manages, what balances, what directs and guides that keratinocyte is the regulatory growth factor, keratinocyte growth factor. So we see the value of dermapen to now instigate release of keratinocyte growth factor, but to now deliver the needles directly to the keratinocytes in question. This now further leads on to conditions such as acne. Acne is threefold. So we understand that our triggers and activators are going to include sebum production, particularly the transition of thicker sebum via the overconversion of DHT or dihydrotestosterone. What we also see with the acne condition is then retention hyperkeratosis. Retention hyperkeratosis is the closure of the top of the follicle and is the slowing down of keratinization, which contributes directly to clogging and congestion. This in turn leads into the third area of acne formation, which is bacterial proliferation. P. acnes bacteria, and then a combination of Staphylococcus epidermis and Staphylococcus aureus. So if we understand one of the triggers of acne is retention hyperkeratosis, then we understand that there is also an imbalance of the keratinocyte. So if we can manage, direct, and guide and influence that keratinocyte through dermapen 4, but via the release of keratinocyte growth factor, this now opens up opportunity for treatment of acne. Success with your dermapen 4 will enable delivery and benefit for acne stage 1, comedonal. Comedone, slowing down of keratinization. Stage 2, papulopustular, and stage 3, nodular cystic. At no point do I ever recommend that acne stage 4, acne fulminans, or acne conglobata is suitable for treatment with dermapen. It's not. You will require drug intervention. It's not uncommon to think, well, hold on. If dermapen is working with needles, and I'm going to glide these needles across the skin, am I not going to spread acne all over the face? Am I not going to create a bacterial imbalance? Let's consider the key bacteria related to the acne condition is Propionibacterium acnes. It lives and thrives in an anaerobic or oxygen-free environment. So if dermapen delivers some nearly 2,000 puncture channels per second into the skin, then these puncture channels are going to deliver oxygen into the skin. Just like taking a fish out of water, it can't breathe and it will die. It's the same thing with P. acnes bacteria. If you deliver oxygen to its environment, the oxygen actually kills the P. acnes bacteria. In turn, and we develop this over the next few weeks for an acne specific subject, we will see the reduction of P. acnes bacteria then rebalances the ecology of Staphylococcus epidermis and aureus. So we now see value that dermapen can treat comedonal acne stage 1, papulopustular, but also stage 3, nodular cystic. From the keratinocyte, now let's look at the third most dominant cell found in the epidermis. It's the melanocyte. The melanocyte lives in basal layer. The melanocyte is dendritic, so it's using its dendrite arms to then hand over the melanosome or pigment capsule to the keratinocyte, and this occurs in spinosum layer. So we understand that melanogenesis is not just about the melanocyte, but it's also about the relationship with the keratinocyte as well. So for this benefit, we understand that by directly treating and targeting the melanocyte within basal epidermis, by directly treating and targeting the melanocyte and its relationship with the keratinocyte in spinosum epidermis, then we create not only direct intervention of those cells, but the subsequent release of melanocyte growth factor and release of keratinocyte growth factor now deliver a balancing of that melanogenesis process. In turn, this now opens up ingenuity and innovation just with your dermapen device, no other combination therapies, to now influence the melanogenesis process. This delivers success: melanocyte, keratinocyte, basal epidermis, spinosum epidermis for traditional uneven skin tone, facultative hyperpigmentation or dyschromia, for treatment of post-inflammatory hyperpigmentation, age spots including lentigines, but also freckling or ephylidase. What about two very common conditions in the Indian market, which is melasma, but also ashidermatosis? With these conditions, we understand that the problem or the malfunction is more than just about the melanocyte and is more than just about the relationship with the keratinocyte. What happens with these conditions is the melanin from the melanocyte now begins to move downwards and is taken up by macrophages found in superficial papillary dermis. As the melanin is processed by these macrophages, as it's viewed as a pathogen, a melanin-containing macrophage is now referred to as a melanophage. So we understand that in cases of melasma or ashidermatosis, your success for these indications is the direct targeting via your dermapen of not just the melanocyte and the keratinocyte, but also the melanophage, which is sitting a little bit deeper down in the epidermal junction, but also in very superficial papillary dermis. If we can successfully balance hyper or overproduction of pigmentation via dermapen, via the release of melanocyte, keratinocyte growth factors, epidermal growth factor, and direct intervention of those cells, then it's these same growth factors which can be used for reduction and revision of hypopigmentation. This therefore delivers success for treatments such as Goodhart hypermelanosis, so ultraviolet aggressed hypopigmented spots, often accompanied by lentigines. This can also deliver success and balance for post-inflammatory hypopigmentation, but as innovative combination therapies, which will be an individual topic within itself, drug combination therapies plus dermapen can also be used for innovative treatment of chemical leukoderma, of acral vitiligo, but also of vitiligo vulgaris, or cases of controlled generalized vitiligo. So we understand that the epidermis has value. We understand the key cells, but we also understand the regulatory growth factors, all instigated by dermapen. Let's move on down to the dermis and to the hypodermis. We understand that if you want to treat any condition that is collagen induction therapy related, you need to be targeting a collagen producing cell. That's a fibroblast. The fibroblast is found roughly at an 85% concentration in the dermis, the extracellular matrix, but only about a 5 to 7% concentration in the hypodermis. In the hypodermis, the most dominant cell is the adipocyte, or the fat cell. So we understand that for collagen induction therapy procedures, anti-aging, wrinkles, for scar revision, but also for striae, your needles need to be intervening with the fibroblast directly. So we understand that for these procedures, the epidermis has no value. But I also state that for procedures such as pigment, acne, milia, keratosis pilaris, the dermis doesn't have value. You treat more superficially for this. So as such, we understand that From the makeup of the extracellular matrix, the role of the fibroblast is to release collagen, elastin, glycosaminoglycans, chains of polymucosaccharides, hyaluronic acid, but also the release of glycoproteins, which now maintains the hydration, moisture, and fluid retention within that area. So what balances and manages the fibroblast is fibroblast growth factor. And this becomes released as part of a dermapen procedure when pinpoint blood is delivered. So for collagen production to occur via a microneedling procedure with dermapen, you must see blood. If there is no blood, no collagen will be produced. But on the other hand, you don't need blood for your pigment or for your acne procedures. Likewise, the general manager of all growth factors for balance and management of the extracellular matrix is a family of growth factors called transforming growth factors. What dermapen also instigates through blood procedures is the release of vascular endothelial and platelet-derived growth factors. And it's these two growth factors which manage and balance angiogenesis, the growth and development of the capillary networks found in the dermis, but also found in the hypodermis. But what they also do is create durability, strength, control, and management of these capillary networks. So we understand direct intervention with the fibroblast, pinpoint blood, now opens up opportunity for treatment of anti-aging. So deep and superficial rhytids, wrinkles. It's also through this area that it opens up opportunity for scar revision. Let's talk first off post-acne scars. This includes indications such as rolling scars, wave-like undulations following acne stage 2 and 3. This includes boxcar scars, box-like indentations, particularly following acne stage 3. Ice pick scars following seborrhea, but also following acne stage 2, 3, and 4. This is also where we can treat for anetodermic or rounded pockmark scars. Traditionally, these would follow smallpox. This was eradicated in Bangladesh in 1976, but it's not uncommon to see a small anetodermic scar on the side of the arm following a smallpox inoculation, but also following chickenpox. In addition to treatment of post-acne or atrophic scars, this is also the area that opens up opportunity for treatment of hypertrophic scars. If the hypertrophic scar is controlled, then you can safely treat with just dermapen. However, if the hypertrophic scar is out of control and not stabilized, if the scar is a keloid, then you will require drug intervention with your dermapen procedure. So the dermapen can mechanically break up the existing scar tissue. The dermapen can promote regulated collagen production, but then the drug intervention can then prevent a keloid or profibrotic growth factor response. This also means that we can treat for contracted or burn contracture scars, but even for striae. So we understand that the visual presence of blood, the intervention directly with a fibroblast, now means that we see successful anti-aging, deep and superficial lines and wrinkles. For post-acne scars, rolling, boxcar, ice pick. For anetodermic scars, hypertrophic, keloid, burn contracture scars, but also for striae. Also recall that the extracellular matrix is not just about the relationship between the bundles of collagen fibers and the coils of hyaluronic acid, but these are also sustained, and nutrition and information are delivered via the vascularity, particularly concentrated in papillary dermis. The vessels in the dermis are smaller in size but more frequent by comparison to those found in the hypodermis, which are larger in size but less frequent. So with this, we understand the value of the extracellular matrix is not just about collagen, but it's also about vascularity. So it's for this reason that you can treat conditions such as rosacea, stage 1 erythema totalinjectatic rosacea, stage 2 papulopustular rosacea, Stage 3, phymatous rosacea, which may require case-by-case a drug combination therapy. It's also through this area that you can treat for generalized telangiectasia on the body. We understand the role and the value of these capillary actions within the dermis and the hypodermis are not just sustaining life force and nutrition for the fibroblast, for collagen induction therapy related indications, but it's now delivering growth factors, nutrients, and hormones to sustain hair growth. So we see the value now for treatment of hair restoration. Not all subcategories of alopecia may be necessarily suitable for dermapen procedure, and all treatments will require a combination therapy, as a minimum, a specialized mesotherapy or PRP, but case by case, we can see success for tractional alopecia, cicatricial alopecia, stabilized alopecia areata, early stages of androgenetic alopecia or male pattern baldness, but also moving into areas such as telogen effluvium. Success is paramount that there is still a hair follicle in place. So there is no successful treatment for universalis or alopecia totalis. So what I want to show here is by simply mapping up the skin, identifying a key cell within the layer or sublayers, linking that to a key growth factor or factors released and activated via dermapen 4, and now by simply adjusting your needle depth as required, now delivers direct cell intervention within the skin, now activates as a controlled inflammatory or a controlled proliferative response, regulation via growth factors, regulated collagen production and angiogenesis, which now opens up opportunity. To summarize for the epidermis, milia, keratosis pilaris, stuccokeratosis, comedonal acne, papulopustular acne, nodular cystic acne, facultative hyperpigmentation or dyschromia, uneven skin tone, post-inflammatory hyperpigmentation, lentigines or age spots, ephylidase or freckles, moving into guttate hypermelanosis, chemical leukoderma, moving into post-inflammatory hypopigmentation, acral vitiligo, and controlled cases of vitiligo vulgaris or generalized vitiligo. We understand the relationship, particularly of the melanophage for melasma, but also for ashy dermatosis. Moving down into the dermis and the hypodermis, particularly for scar tissue, if it's still red, blue, or purple visually, you'll only need to treat into the dermis. But if the scar tissue has gone white, you will need to treat deeper down to the dermis, the hypodermis itself. So now this opens up opportunity, anti-aging, deep and superficial rhytids. Now we move into post-acne scars, rolling, boxcar, ice pick, anatodermic scars, hypertrophic scars, drug combination therapies for keloids, and drug combination therapies for burn contracture scars. We add in striae. The value of the extracellular matrix plus the vascular activity now opens up opportunity for indications including rosacea stage 1, erythemotelangiectatic rosacea, stage 2, papulopustular, stage 3, phymatous rosacea. This now opens up opportunity for telangiectasia, and in turn, regulation of these blood vessels can open up opportunity via combination therapies for treatment of androgenetic alopecia, tractional alopecia, cicatricial alopecia, alopecia areata, but then also moving into telogen effluvium. So it's for these reasons that we now see the opportunity of growth for the indications that you can treat with dermapen and dermapen 4. Dermapen 4 now works even more concentrated to effortlessly and flawlessly deliver via infusion with 1,920 puncture channels per second, the DP dermaceuticals. This now delivers not just dermapen, regulatory growth factors, angiogenesis and collagen deposition, but now the procedural actives contained in each of the DP dermaceuticals to further customize, but to further deliver concentration and precision for even greater response, particularly for conditions, hyperpigmentation, acne, anti-aging, scar tissue, rosacea, now enabling the widening of treatment success and programs. Add in combination therapies such as PRP, and this further grows. That concludes the formal part of today's presentation. I want to share with you some of the strangest uses I've seen for dermapen across the world, and then I'm going to go through some of the questions for you. This became apparent to me in January this year, and it was a veterinary surgeon in Poland who decided to create innovation for a condition known as alopecia X. Alopecia X is a condition which affects Pomeranian dogs and sees massive hair loss for these dogs in sporadic areas, if you think similarly to something like alopecia areata for a human. And so the veterinary market in Poland is now using dermapen for treatment on Pomeranian dogs to treat and target the effects of alopecia X to sustain hair growth for pet dogs. I've also seen innovation for a surgical team based in Zagreb in Croatia who are using the needles of dermapen to directly treat and target the uvula at the back of the throat and also the surrounding soft palate tissue. What this does is now enables a tightening via collagen induction therapy, which can reduce the vibration and the effects of snoring. I've seen innovation for the podiatry market in the United Kingdom for combination therapies for treatment of planters and mosaic warts, innovation for intimate rejuvenation, the gynecological and the urological market, but even moving into very traditional dermatology, combination therapies for treatment of neurofibromas, but updates for photodynamic therapy. And of course, we see success in the trichology or alopecia market. From these very strange indications and uses that I see with dermapen, let me have a look at some of the questions that we have. So the first question which I've received is the process similar for chickenpox or anatodermic scars that we would treat for something such as post-acne scars? Essentially, yes. For a boxcar scar, you would have a box-like indentation, but for an anatodermic, it's more rounded or a pock mark for this as well. So with this, we would be treating every 6 to every 8 weeks, but you need to see a minimum of pinpoint blood. No blood, no collagen. But on the other side, you don't need to be seeing extensive blood coming through. The next question asks, how effective is dermapen in conjunction with PRP for hair loss? The number one rule for all practitioners watching today, there must be a hair follicle that is not dormant and that is intact. If there is no hair follicle, no amount of dermapen, no amount of PRP is going to be able to sustain hair growth. This is why in cases of alopecia that is androgenetic or male pattern baldness, the sooner you begin a treatment plan, then the more effective it will be. But once that follicle becomes dormant, you will experience no success. So combination therapies can be useful, particularly minoxidil, applied daily to maintain follicular maximization. The minoxidil is only suitable for androgenetic alopecia and for cases of telogen effluvium. It's not suitable for other types of alopecia. So PRP is a case by case, but there must be a follicle in order for this to work. I've received another question, what about use of a topical local anesthetic or use of anesthesia for a dermapen procedure? I don't use any form of topical local anesthetic for any of the procedures that I treat or for any patient. As controversial as this is in the Indian market, there are reasons for this. First, from a profitability perspective and any aesthetic procedure you perform, you need to work out the figures. Your dermapen is so powerful that at top speed at 120 revolutions per second, it's now creating such power that you can now deliver quick, fast, and effective strikes. This means that you can treat a full face in as little as 3, 4, or 5 minutes. Yes, there are some areas of discomfort, but it's only 12 seconds, 14 seconds. It's over very fast. The second reason why I choose not to use topical local anesthetic now is because not only of treatment speed, but the oscillation delivered at full speed now dissipates your nerve receptors and your Merkel cells, creating a vibration which confuses the sensation and delivers greater comfort for the patient, even without topical local anesthetic. The key reason why I don't use it is because the agents which enable depth into the skin, and these are called ester anesthetics, and these include tetracaine and benzocaine. These are all highly renowned vasoconstrictors. If you apply this onto the skin and your expectation is to draw blood, but the tetracaine or benzocaine is preventing blood coming through, you can see the challenge, you can see the conundrum of the treatment as to why you're going to experience a loss of success as well. The next question asks, particularly for acne, what is the action of the dermapen to deliver oxygen into the cells? It's the needles. At full speed, at 120 revolutions per second, you have 16 33 gauge needles now creating punctured channels into the skin, which consequentially is going to deliver oxygen into the skin. As such, following on with the next question, particularly if there is an underlying hormonal imbalance, which is contributing as a trigger for cystic acne, nodular cystic acne, particularly moving into acne fulminans or acne conglobata, you will need a combination therapy. So whether that is going to be a hormone regulator, whether that's going to be something such as supplementation with zinc. The next question asks, what about PRP and delivery at what depth? I never talk depth with dermapen. And the reason why I don't is because mathematics and microneedling do not work. You need to look for a visual response. If you see the skin is no blood and the skin has no color change, you are working on stratum corneum and you're not going to see a result. Too superficial, no benefit. If you see no blood and the skin is pink, your needles are working in granulosum. No blood and the skin is red, your needles are in basal spinosum. If you see just the occasional sporadic pinpoint blood, your needles are in the epidermal junction. If you see consistent pinpoint blood, your needles are in papillary moving down to reticular dermis. And if you now see mild to moderate amount of blood coming through, your needles are in the hypodermis. So working visually is your absolute cue. For PRP procedures, you need pinpoint blood. So whatever depth gets you there for pinpoint blood. The final question is contraindications. There's no surprises here with dermapen procedures, even by comparison to your other injectables, laser procedures, or anything else you may be offering. Obvious ones include active bacterial or fungal infections on the skin, any undiagnosed pre-skin cancers or any active skin cancers. Also, check out for any actinic or solar keratoses. Patients who are hemophiliac are not suitable for the procedure, and bear in mind also that if the patient is undergoing an autoimmune condition that is in active phase, such as lupus, such as vitiligo, scleroderma, these patients are not suitable. For alopecia areata, all of these autoimmune diseases must be stabilized for at least 6 months before considering whether treatment is going to be. Just one more question and then I'm finishing up, is how deep do I need to go, particularly for stretch marks on the buttocks? This relates into what I've covered before. Whatever depth gets you, blood. So you will find patients' diet can change. If your patient has lots of coffee, if your patient has alcohol in their system, if your patient has any aspirin or blood thinners, they're going to bleed easier. If they don't, then they won't bleed so easy. So whatever depth gets you that pinpoint blood, simply turn your needles up and simply turn your needles down to customize for each indication, for each patient, for every procedure, for pinpoint precision, every patient, every time. That concludes today's webinar. I'm going to hand you back over to Umang Bambri from Dermapen World India. Thank you so much, and I look forward to catching up with you next week, where we have a very comprehensive topic, which is hybrid of mesotherapy and microneedling with Dermapen 4 and DP Dermaceuticals. Thank you so much, and I can't wait to catch up next week, same time, same channel.
Thank you, Andrew. It's been lovely hearing you out. And with these topics, I think we're trying to add more action into microneedling with Dermapen 4. Thank you, audience. Just for a small announcement, we have two webinars in the next week. One on the 28th of April, same time, by Dr. Andrew Christie, and another one on the 29th of April by our international KOLs who are a part of plastic surgery and from the medical background. So please register for both of them and look forward to seeing you again. Thank you.